I was asked to introduce myself. I'm Jonathan Golub. I'm a professor at the Johns Hopkins School of Medicine, School of Public Health. And I do TB research. I'm an epidemiologist by training, and I'm in the School of Medicine at Johns Hopkins. And I mentioned also School of Public Health. School of Public Health is my real home. It's where I teach and where I advise students. But School of Medicine is where I was hired. So I'm one of the few non-clinical people in the School of Medicine and the Department of Medicine there at Hopkins. I'm not saying that as bragging at all, in many ways it's a pain in the neck, but it's still just to note that I'm a non-clinician in epidemiology. I'm an epidemiologist. I'm trained epidemiologically. This is a little bit of what we're going to talk about. TB survivors and non-TB conditions and comorbidities. This is a little bit of an outline. We'll talk a little bit about burden of TB survivors, how many people in the world are currently living who have had TB in the past. A little bit about morbidity and mortality among people with TB and TB survivors, and the need for interventions for what I'll refer to as non-TB comorbidities during and after TB treatment. And there you'll hear us talk a little bit about what we talked about the last couple of hours with Yohai and some of his work as well, and then some concluding thoughts about that. So this is taken from the WHO Global TB Report. It's a year old. I haven't updated it from the most recent report, but it basically gets the gist, which is to say that with all the different things that we've done for TB, the new treatments, the new diagnostics, preventive therapy, over the last 10 to 15 years or so, we've saved about 44. That's great. We could do better, but we're doing very well. But because of that, the nice thing is we have a lot of people out there who are TB survivors. People who are living, who have had TB, have completed treatment and are out there and potentially at risk for post-TB lung disease. So this is something that was written about 4 years ago. They're in the process of updating it, but quantifying the global number of TB survivors. And it's a modeling study, way too busy of a slide. So this is the summary here. There are 155 million people. That was as of 4 years. It's from that. But basically, the summary there is the number of TB survivors alive in 2020 is more than 10 times the estimated annual TB incidence. We have about 10 to 11 million cases of TB a year annually. Interventions to alleviate respiratory morbidity, screen for and prevent recurrent TB, and reduce the stigma should be immediately prioritized for recently treated TB survivors. So as I said, so we're going to mix and match a little bit in this talk. We're going to talk about a little bit of what can be done for people post-TB, but also what can be done for people during TB. So this is something that was put together by a group several years ago. Looking at this idea, so what you look at here is if you look at this first square, imagine this is before you have active TB. You'll live, hopefully, a healthy, productive life. Once you get TB, then that gets discounted a fair bit. And all of a sudden, you're at greater risk of dying during this period of time. Now, immediately after TB, it doesn't bounce back right away. But this risk of early mortality and mortality due to a lot of the complications and disabilities that come from your TB disease. And this can last throughout your lifetime. Now, more recently, they did add some numbers to that. I'm not going to go through all these numbers. They made it a little fancier, as you can see. But the point here is that when you look at the mortality and morbidity, really the mortality due to TB post-TB, then you really start to see that there's a whole lot more going on. It's not just how many people are dying of TB post-TB as well. So a few years ago, Camilla Romanowski and team put together this review that many of you have probably seen to try to look at what are people dying of from TB post-treatment. People who have had TB, are they at greater risk of dying post-TB? And if they are, what are they dying of beyond their TB treatment completion? So what they found, first very simply, is a threefold increased risk. So the number of observed deaths for TB survivors was almost 3 times higher than the expected number of deaths. So people who have survived through TB were at still a threefold increased risk of dying earlier than people who never had TB before. Oops, that jumped very far ahead. Okay, and that these results were consistent in subgroup analyses. Pulmonary TB, threefold increased risk. Males and females both at an increased risk. Age under 60, greater than 60 at an increased risk. High-income countries and middle-income countries also at a similar risk. So this was really something that was across the board, that people with TB were more likely to die post-TB than people who never had TB before. What were they dying of? Number one, cardiovascular disease, then followed by cancer and respiratory disease. So about 20% cardiovascular disease, about 19% cancer, and about 14% respiratory. Now, just to put it in perspective, death due to TB or TB-HIV accounted for 9% of the causes of mortality. So people post-TB were still dying of TB, but that was actually lower than what they were dying of other causes. Now, to put this, just to explain this relationship a little bit more, just to say this relationship between TB and mortality is complex. So imagine here you have the people with TB. This is the time period during TB disease. People are either fully treated or inadequately treated. They could be missed altogether. They could be misdiagnosed. And of those who are missed or misdiagnosed, they're probably going to die fairly quickly during TB treatment. And you see here mortality before, during TB. Then some people are going to, they're going to survive, and they're going to have post-TB sequelae, and some of the things we'll talk about in a bit, and recurrent TB. They're more likely, if you've had TB once, you're more likely to get TB again at some point in the future. And all of this contributes to this mortality and morbidity due to TB. This is supposed to be an iceberg, showing you that the mortality before or during TB is something we document well. We know when people die during TB and when they're sick during TB. But the morbidity and mortality after TB is something we don't have a great accounting of. But this shows us that TB is likely associated with even greater morbidity and mortality than current estimates capture. And importantly, all these comorbidities that we're going to discuss today, that Yohei so nicely discussed in his thesis as well, and these social determinants affect this all throughout the life cycle here. They affect people getting TB, they affect people surviving TB, and they affect people post-TB. So Tony Harries and others took this all into account, and they said maybe we should be considering a fourth 90. Now, first, I should tell you what the first three 90s are. And this was stolen a little bit from HIV, but what they basically said there already was in place, but most of you probably don't know about it. I didn't know about it until to know that you want to reach and treat at least 90% of all people with TB. As part of this approach, we want to reach and treat at least 90% of the key populations, those people who are at greatest risk of progressing to active disease. And we want to achieve at least 90% treatment success for all the people diagnosed with TB. And these are good goals to strive for. But how about a proposed fourth 90, ensuring that 90% of all people who successfully complete treatment can have a good health-related quality of life? We've treated them all. We've had them in treatment for 6 months, maybe 9 months, maybe 2 years if they were drug-resistant TB in certain places. And during that whole time, we have this opportunity to try to screen them and treat them for diabetes, malnutrition, HIV, smoking, alcohol, mental health, pulmonary impairment, all these things that put them at greater risk of developing TB in the first place, and all these things that keep them in great risk of further morbidity or mortality post-TB. So we like to look, WHO likes to look at the big five, so to speak, risk factors: undernutrition, alcohol use, smoking, HIV infection, and diabetes. And they come out with this each year in their report, and it shows that the population attributable fraction. So what number of the 10 million cases or so that are reported each year are due to these five risk factors. And you see here that just under 1 million are due to malnutrition. Alcohol is about 750,000, smoking is around 700,000, HIV infection just over 6, and diabetes around 300,000. And these are based on the ideas of what the current estimates are for the relative risk or the odds of an individual who has TB, who is infected with TB and has one of these co-infections, or I should say co-infections, non-TB conditions, and their risk of progressing to active disease. So in other words, here's what we see this with alcohol. This is the estimated percentage episode of TB, so incident cases in 2023, that are due to alcohol. Now, alcohol has about a threefold increased risk for TB. So people who are infected with TB and also drink, they have about a threefold increased risk. Now, that's a rough estimate. There's wide ranges of this, and it depends on how much you're drinking, but a rough estimate of threefold increased risk based on the population of people who are drinking in the world. They've come up with these attributable fractions that you just saw in the slide before. But this shows the global estimates on what proportion of people in these different countries their TB is attributable to alcohol. And you can see the greater than 15% or so is the dark blue. So here in the U.S., we see alcohol as a major driver for tuberculosis.
But here in the UK as well.
Yes, in the UK as well. So, and a little less so on the African continent, but still 10 to 14%. You see it with diabetes, which has only a 1.5-fold increased risk. There's a whole lot more people in the world who have diabetes. So you can see that's a bigger driver in certain areas, a little less so in the US, UK, but certain areas, in Northern Africa and Eastern Europe, it's a little bit higher. In India, it's higher. In China, and also in Southern Africa. And here you see HIV is the driver, where that drives. And you see now the difference with HIV, of course, it's an 18-fold increased risk of TB. If they have HIV, they're very likely to get TB if they're infected, and they're not on antiretroviral therapy, which also reduces their risk. Now, luckily, in many places of the world, they are getting on antiretroviral therapy, so that risk is going down. Which is why you see a lot of the lower incidence rates of TB in places in Southern Africa, for instance. Here's smoking, which is similar to diabetes, about a 1.6-fold. Smoking is very widely prevalent, is going down in many areas of the world, and you can see where it plays a bigger role. And then we have one more, undernutrition. Undernutrition has a 3-fold increased risk. And also has, actually, that's not right. Isn't it about a 1.5? Yeah, I'll ask you. That was a mistake I put in there. I'll ask the guy who should be an expert on this right now, because he just studied this for the last several months and years. But the thing with undernutrition, population of people who are malnourished is tremendous compared to all the other factors up here. So even a lower risk is associated with a much wider prevalence in the world. Now, I'm sorry?
How are they measuring that?
Yes, BMI.
It's BMI.
That's all BMI.
And the alcohol use?
The alcohol
I feel like in South Africa.
it's all self-reported. So it's, this is just this estimate based on whatever surveys are out there. Right?
Yeah, and just to chip in on the undernourishment. And we were at a talk by Matt Saunders yesterday, and he was saying for a start they've changed their definition of undernutrition to just like a category yes, no. Are you BMI 18.5 above? Doing so, they've reduced from 3.2-fold to whatever we said. Yeah. So and it's brought down the number of cases attributable.
So this number in last year's report was out here. Yeah, this was out here, and now it's
He
here.
was complaining about saying it's really.
It was interesting. I actually had the slide. I was going to show that slide and show the change, so I'm glad you brought it up. Yeah, that was the biggest difference between last year's report and this. This dropped from here to here, and it's because of the new definition.
Find the fact that we know there's been a lot of characteristics and that sort of.
So this is looking at these same numbers and the same big five just from 4 different countries that I chose. I chose them selfishly because that's where I work in. So, but just to show you that in places like Brazil and South Africa, HIV is the primary driver of TB. But you look at places like China, where smoking is and alcohol use, and in India, malnourishment and alcohol use are the big drivers. So this differs depending where you are, and how important it is to understand the epidemiology of where you're studying to understand what populations you want to go screen for TB, as we were talking about with Yohei earlier. It will differ in different countries, and even within the country, it will differ even within certain areas. So each of these risk factors increases the risk of bad outcomes, relapse, or death during treatment. And these risks, they're all modifiable risk factors, and they increase the risk of recurrent TB and death after TB treatment. So this is what's important here, to be able to say that these are modifiable. These are things that we can actually do something about. and they will save lives during TB treatment and improve the people's health beyond TB treatment so that they don't get TB again, but also so they don't get many of the other things that are bad, not TB. So here I'll just show you a little bit of how prevalent are these non-TB conditions in people with TB. This is looking at in India in some work that I'm associated with, in Africa, in Kenya, Uganda, Zambia, and Zimbabwe, in a group, in a project led by Tony Harris's group, and China, also a group that led by Tony Harris that I worked on a little bit. But basically, you can look at all these individually, but what you're seeing at the bottom is that at least one of these conditions is present in 44% of people in India, 72% of people in these African countries, greater than 45% at diagnosis in China, down to 25% at the end of TB treatment. So this Africa one was the end of TB treatment. India was at diagnosis. So you can screen people for these things at different times. And there's different reasons to screen for at different times. At diagnosis, I think you're screening for it so that you can actually treat it during TB treatment. At the end, you're diagnosing it so you can treat it post-TB, which may be more of a challenge. Persons come in, they've gotten their treatment for 6 months, and now you're saying, hey, now we want to treat you for your diabetes or your smoking, and they want nothing to do with you at that point because they've completed their TB treatment and they want to go on their way. Now, this change here, I'll describe in a few minutes of why that happened. And then looking at attributable fractions for poor TB treatment outcomes. This is a paper that will be published soon from the report group in India, and this was based on in the prior slide for India. But basically, the underlying theme here is that in India, undernutrition and alcohol misuse accounted for over a third of all unfavorable treatment outcomes. Those are the two that really are taking care of a whole third of all TB. And if you can manage to provide these people with nutritional support, which you'll see if you don't know about the ration study, I'll talk about that in a few minutes. And alcohol misuse. If you can help people reduce their alcohol intake at the time of TB diagnosis, you can have better outcomes throughout. So these are, because remember, these are attributable fractions for poor treatment outcomes, not for developing TB, but once you have TB, what can you do for them? So now we'll talk a little bit about prevalence of non-TB conditions in TB households, a lot of what Yohei has been studying. Should comorbidity screening and treatment be limited to the person with TB, or should it also include their household contacts? For a while, we'd like to talk about the idea that TB case is more likely to have these various conditions that we've been talking about, and we want to try to treat them for those conditions. But a lot of these conditions, if the TB case has it, their household contacts very likely have it as well. And what's a good example of this is the RATION study. This was a clinical trial done in India. RATION stands for Reducing Activation of Tuberculosis by Improvement of Nutritional Status. It was a cluster randomized trial to assess the impact of nutritional support for household contacts of people with TB. So very simply, what did they do? They took households, they first took the 2,800 TB patients, and they identified their household contacts, and they they split that up into two groups, so 14 clusters each. The control group were on the usual diet. They ate whatever they were normally eating. But the intervention group received food baskets and multivitamins for 6 months. And the primary outcome was a difference in incident cases in household contacts in both arms in 24 months of follow-up. In other words, if you identify a lot of malnutrition in the households of TB cases and you provide them nutritional support, well, that reduced their risk of developing TB in the future. And the answer was yes. This is the Kaplan-Meier curve, and you can see here the adjusted hazard ratio of about a 50% reduced risk in people with microbiologically confirmed TB. And this was followed by a great editorial that said, food, the tuberculosis vaccine what are we looking for in a vaccine? We're looking for a vaccine to reduce TB incidence by at least 50%. And here we gave people food, nutritional support, and we reduced TB incidence by 50% among people who were recently exposed, most likely infected, and at great risk of progressing to active disease. So this is the reason I show this is an example of a potential comorbid condition or a non-TB condition among people with TB and in their households that can have a significant impact if you. So in a recent paper by Calderwood, in that took place in several African studies, Mozambique, Tanzania, and Zambia. They looked at HIV, malnutrition, and other non-communicable diseases among TB-affected households. And they found, what they found here, this looks at the prevalence of these chronic conditions, and they looked at them across the board in men and women. But the point here is showing how high they were. 17% were HIV positive in the households. Had diabetes, 37% hypertension, 17% anemia, 15% were underweight, 30% were overweight, which ironically actually protects from TB. But we still aren't suggesting that people should be overweight, and 10% with chronic lung disease. So showing the high proportions of these different conditions among household contacts of TB. Now, I should note before I jump into Yohei's work is that they didn't find much of a difference between the level of these conditions and the neighborhood controls. I forgot to put that slide in, but basically they found similar proportions in the neighborhood controls. And similar to what Yohei found, which is here's one of his studies, a pilot cross-sectional study of non-communicable diseases in TB control in TB households, looking at, and you see diabetes here in the household contacts and in the neighborhood controls. And you see 12% versus 14%, not a major difference. Newly diagnosed diabetes was 9% and 12%, hypertension 39 and 45%. I would ignore these adjusted odds ratios. You can see none of them are statistically significant, suggesting that basically there were no differences other than alcohol use, which was 38% in the household contacts and very high in the controls. Forgot to ask Yohei about that in his exam, why he thought we saw that, but he can answer that later. But very high in both groups. So this, and why do I show this? And also, let me just finish here, and then I'll talk about that. So this is another one of Yohei's studies looking at tobacco smoking clusters in households affected by TB, and individual participant data meta-analysis. And I just highlighted some of this. So what you see here is the age among people, members of households without TB, and the members of households with TB, and this is the people, actually, the TB case. But you can see not much of a difference in age. It's lower than the people with TB, as one would expect. The people with TB were a little bit older. This was their household contacts who are younger, sometimes children, or, well, at least adults over 15. Gender, you see similar across the board, but more likely to be male. In the TB case, but looking at these non-TB conditions, you see similar alcohol among the household contacts, household of people with TB and the households without TB, and you see similar smoking, you see similar diabetes, and you see similar hypertension. So all of this to say that this brings up a dilemma in some ways. And this idea that we want to say we should go into TB households and we should screen everybody for these different conditions and provide them care. And I am a strong proponent of that. That's what I want to do. That's what I want to write grants to do and studies to do. However, it brings up this dilemma of that here Liz has TB and their household has a lot of these conditions. But you are their next door neighbor. Nobody in your household has TB, but your household has all these conditions. And the reason I'm providing care to you is because you were lucky enough to get TB. And now I'm providing all this care to your family, where I'm not providing. And I'm bringing this up in front of a TB crowd. So to me, when anybody brings this up to me, I say, well, I'm a TB person. I do TB research, and that's my entry point in home. But people who I talk to who aren't necessarily just TB people say, well, why shouldn't we be doing this for everybody? And Yohei talked about this in his dissertation as well. We should be doing it for the community. That's very expensive. So whether TB is the right entry point or not, it is a entry point. But you'll have to know that you're kind of selecting these people who have TB, and that puts them at risk, sure, but only because somebody over there wasn't lucky enough to get TB just yet. So now I'll talk a little bit about what's going on, what people think. There's a framework for collaborative action on TB and comorbidities. Clearly, I don't expect you to read all of this, but I'll highlight one of them, which is the very last one on the bottom. Conduct operational implementation research to inform policy, programming, and service delivery. That's the one where I think is the most important. We know that this is a problem. Yohei's work has shown it's a problem. Other people have shown that it's a problem, that people with TB have a lot of other stuff going on. And we want to get out there and we want to treat it as soon as possible. A whole lot of studies. Now, we do need to figure out how best to treat it, but doing operational research to do that and to inform policy change at a country level, I think, is what we should be aiming to do. And all of this leading up to this bottom level is preparing for that. And I will talk about that on our last slide. We'll talk about the different ways you have to think through this to get there. And there's a lot to think through, but we want to get there as quickly as we can. So one thing we talk about is the term. Obviously, the goal here is we have people with TB and we want to give them care for these other non-TB conditions, comorbidities that we keep talking about. So in that report, I did not make this slide, in that report, they show several different models of this. One is separate services. So you can sit there at the TB services, you screen people for all of these things, and then you refer them out for true diagnosis of the comorbidity and treatment. And at those other services, they can also screen people for TB and send them back. Now, this requires a lot of work. You screen them, then they go out and they go try to get diagnosed. And when they get diagnosed, hopefully they start their treatment there or they come back to you for treatment. But there's a lot that has to happen. These services have to be in place. There have to be places for them to go to. And depending where you are in the world, there's a different level of how good these services are. And then similarly down here, this is another one, just TB services. Close to comorbidities, the TB services then refer for treatment. That's a little bit better. That way you're screening, you're getting a hint of it, you're getting an idea that they might have this, and then you're diagnosing it for sure. And then you're sending them out. That way you can send a message with them a little bit that's stronger than just, we think this person has one of these comorbidities. Now, another is co-located services. The TB services screen for and diagnose comorbidities, then refer treatment by another healthcare worker, but healthcare worker in the same vicinity. The world has this, but when you have co-located services, you can do this. And then the other stuff is a one-stop shop. You do it all at the TB center, or you do it all at a primary care center. You do it all with a community health worker. These are different models that you need to think through and will be different depending where in the world you're doing this work. So this, certainly don't expect you to read, but this is something that came out a couple of years ago, this policy brief. I'm now working with a group that's kind of trying to make this more operational. A lot of this is looking about pulmonary rehabilitation and different rehabilitation services you can provide to people with TB who develop disabilities during their TB. And that's something that we want to provide, because a lot of people are coming out of TB with a disability of some kind. And we want to be ready to provide that care to them. So in summary so far, a TB diagnosis is an opportunity. It's an opportunity to provide or improve the healthcare linkage. We should or we must screen and provide the following to people with TB, hopefully their household contacts as well. We can treat that. We can screen and treat them for diabetes. That's something that's already being done in many places. India, China have put out guidelines to do that. It's varying degrees. I'll talk to my colleagues in India and they'll say, yes, we're doing it. Then when you look into it, they're screening a lot of people, but that's the end of it. Once they screen them, they refer them out, and very few people are getting treatment. Smoking cessation, counseling, treatment, it's being done. It's being done to the effect of, do you smoke? Yes, you should stop doing it. And maybe they do it again when they come in a month later. Maybe they do it again when they come in a month later after that, but it's not sitting down with them and giving them true smoking cessation counseling. It's not giving them a patch. It's not giving them any drugs to try to reduce it. That's happening very rarely in most places. Alcohol reduction interventions, we know that they can be effective. And I should mention that smoking cessation interventions that have happened have been extremely successful. It's astronomically how high. We get 60, 70% of people with TB that quit smoking during TB treatment. But there's very few studies looking beyond to see if there's any lasting impact. Alcohol reduction, very little is happening among people with TB, even though we know what a big risk factor it is for developing TB, but also for bad TB treatment outcomes. We're part of a study in India that's looking at some counseling for that right now, but we don't have any results yet. Nutritional support, you saw the ration study, we know it works. And India is now providing nutritional support to people with TB and to their household contacts. It's kind of a default in the ration study where they were providing it to the person with TB and the household contacts in one arm, and the other arm just to the TB patient. They knew it was going to be shared. After all, if I'm a TB patient, I have starving children at home, and they give me food, I'm obviously going to share it with my household. Mental health interventions. We know that mental health can have an impact on your immune system and reduce your risk of progressing from infection to active disease. So there are many mental health interventions that can be given by lay people. We don't need professional people to do this. There are several that are happening, and this is all the rage. There are many grants that are happening right now. I've been reviewing them. I submitted one that's under review, but many people are doing this now because it's something people think can be integrated care because it may not provide this professional. But you go to places like South Africa, and I go to TB clinics, and they tell me, oh, we have a mental health specialist. How often are they here? Once a week. And they're there once a week, and they're overrun with patients, so they're not seeing close to everybody they can potentially see. Hypertension treatment is available, and it's really just giving somebody getting somebody's blood pressure done multiple times, but you can, if you do it right, you can do it. HIV treatment, I put that in parentheses because that's actually happening. Then there's pulmonary rehabilitation, which is something that's happening very rarely. I'll discuss that in a few minutes. And then financial improvement, something we can't forget, is that there's something called catastrophic costs, which lots of people suffer, which is a large proportion of the household's financial situation goes towards TB, and therefore they're in poverty at the end of TB treatment. And this is something that can be managed in a lot of places. Even if treatment's free, that doesn't mean their costs disappear. Travel and you often lose their job, but there are ways to apply for grants. There are ways to navigate the system to try to help you. And that's something that we should be helping people with too when they get TB. They shouldn't just be left on their own to figure that out. So we realized we should be doing all of this. A couple years ago, we did a scoping review to try to see how many of these interventions were actually happening for people with TB. So we took a look at alcohol use, depression, diabetes, smoking, lung disease. We actually ruled out smoking and didn't look at it because, as I said, there's so many happening with smoking. It's just that they're not being followed in that literature because it already has been. So we found 20 such studies a few years ago when we looked at this. 17 were conducted in low and middle income countries. 16 were happening during TB treatment, and only 12 were published after 2011. So not a whole lot was happening. And where were they happening? Respiratory disease. There were 5 pulmonary rehabilitation studies. There were 6 cardiovascular disease or referral for diabetes and hypertension care. There are a handful of substance and alcohol use disorder studies and a handful of mental health disorders. And so those were the only ones that actually had interventions identified. Not a whole lot happening. So I want to focus. So the point was, not much is happening. More has to happen. We'll discuss that more in a few minutes. Pulmonary impairment. How much time do I got? Okay. Am I boring you yet? I can skip through things because we're tired. So I'll talk a little bit about respiratory impairment because it's something that I've become a little bit more passionate about recently. So respiratory impairment is common in treated pulmonary TB cases. 20 to 70% of treated pulmonary TB cases have lung function impairment. It's not shocking. Person has TB, it affects the lungs, so you expect some impairment. The degree of impairment may correlate with the extent of disease. People who have cavitary disease are going to have more lung impairment. Now, we have seen that lung function improves with treatment, but may not normalize despite curing your TB. So 50% in this particular study, 50% of people with lung function impairment at treatment initiation, 25% by treatment completion. And the greatest improvement happened within those first couple of months. So if we can get people to improve their lung impairment somehow, now some are doing it spontaneously. As TB treatment kicks in, they get better, their lungs improve, and therefore they're not impaired by the end. But a good proportion still, 25%, still have residual lung function by treatment completion. And a couple other studies that have shown that this impact on the lungs can last for a long period of time. 65% of pulmonary TB patients had abnormal lung function 14 to 18 years after successful treatment. And every episode of pulmonary TB was associated with a approximate 200 milliliter permanent and irreversible loss of lung function. So basically 5 to 10% of lung function was lost, and that did not come back. And if they had multiple episodes, then this got worse.
So that was gold mines, wasn't it? I just read
Yes.
that the other day.
Yes. Yes, it was, which is obviously a special population, as we know, and are exposed much more than most people. So, so this has led to a study that we actually are just starting enrollment for in the next month or two, the TB Pure study, the pulmonary rehabilitation to reduce post-TB morbidity. The few studies that have been happening for pulmonary rehabilitation have almost, I was saying earlier, you treat the patient, then you look and see, oh, look at all these people who have a pulmonary impairment. Let's provide them pulmonary rehabilitation now to improve their lungs at this point. A little bit harder to keep these people interested, but that's where most of the studies have gone. And we were thinking, why don't we do this during TB treatment? Again, we have the person in front of us. They're sitting there, they're getting treated for 6 months. Why not throw something else into the mix? So that's what we're doing. Our study is to look at providing either 2 months of pulmonary rehabilitation versus 6 months of pulmonary rehabilitation. So that's a study. I'll come back in a few years and give you the results.
And rehabilitation being
so pulmonary
physiotherapy.
So physiotherapy. So it's interesting. So we're working with a physiotherapist who has created pulmonary rehabilitation programs to be done in people's homes. Because we're talking in India where people are a facility, it's not great facility for pulmonary rehabilitation. You can't just bring people in and have them work out in the gym. They don't have that. So this is developing a program that will be run by an app at their homes, and involve whatever they have. If they have water bottles, fill the water bottles and use those as weights, sitting and standing, finding a space for them to walk back and forth. 6-minute walk test is our primary outcome, which is a test where you walk for 6 minutes and you measure how much, and if they walk a certain amount, then they're considered okay. If they walk less than that, then they're considered. It's one of our outcomes. It's a rough outcome, but it's been the one that's been measured. We're also doing spirometry on everybody to look for improvement, et cetera. So, but yes, it's basically, we're in development of what the actual pulmonary rehab will look like, but it's going to basically be simple exercises that people can do at home and follow through an app so they can report it to us and we know how often they're doing. So going back to that paper that we talked, the scoping review, something we thought about when we read that is the decision to screen, the decision to treat. And this is something we've talked about for ages, and not just in TB, but in the world for anything. And to me, the simple answer has to be yes. And we talked about this earlier today with Yohei's work, which is wonderful and great. And he screened a whole lot of people or looked at screening for a lot of people, but what's next? If we identify all these things, we need to be able to do something for them. So this is a study, I referred to it earlier, but a quick and dirty study we did in China, where we basically went to, we enrolled TB patients with drug-sensitive TB at 4 different time points. And at each one, when we found that in these comorbidities, we referred them to care. Referred. We didn't provide any of this care. We just said, hey, you should go and get checked out for your smoke. You should try to quit smoking. You should go someplace to try to get your alcohol down. You should go someplace for nutritional support. You should go someplace for your diabetes, your hypertension, your mental health. And we screened people as they started anti-TB treatment and said, go. We brought them back in 2 months later and said, how you doing? Did you go anywhere? No, go. And we screened them again as they complete TB treatment, and again 1 month after treatment. I'm not going to show you all the results, but I'll show you here's a TB registration, the diagnosis, and at end of TB treatment. So you can see the numbers, how they change. So 85 people with diabetes at TB registration, 73 at the end. No diabetes dropped down a little bit. New diabetes, not surprising because you diagnosed them here. You weren't going to find too many new diabetics at the end of TB treatment. High blood pressure did go down. Systolic blood pressure went down. Mental health disorder, depression, and all these things didn't have many people who registered. Now, some of these things will go down on their own. Some went down because they went out and got referred. Now, this shows the cigarette smoking. So cigarette smoking went 13 to 27. Excess alcohol drinking from 60 to 6. Current exposure to silica dust. Again, that's just if they if they left their job potentially. Malnutrition declined a bit, and their 6-minute walk test I talked about improved for many people. Now, taking
cigarettes, did you have any follow-up measures?
No, it's all self-reported. This was a very quick and dirty study. We did an earlier study with the same group where somebody said to me, "Do you have $1,000 you can support this study with?" And I said, "I think I have that in my discretionary account." And that was for one person to go around to many TB clinics in China, and they knocked it off like that. And that study was really just to go in at the end of treatment and see if we could screen for things. How long did it take? And were this patients willing to let you test them or ask questions? And did the healthcare workers think that it took a lot of time? And since they were able to get it done and it didn't take a lot of time, we did this next study of doing it at the different 4 time points. So we did do A1C for diabetes, but we didn't do anything. We didn't do any cotinine or anything, urine testing or carbon monoxide for smoking. Yes.
What interventions did you drop in?
All with referral. This was all just, hey, go and get checked out. We didn't have any services in place. So this was, like I said, as quick and dirty as can be, just alerting people that they had this problem and that they should do something. We did some very brief counseling and then sent them on their way. And then checked in 2 months later. Did you get the care? Checked in 4 months later. Did you get the care? Checked in a month later. Did you get the care? So, like I said, very quick and dirty. I wouldn't necessarily recommend this. This was just to show that if you screen people for it, you'll find it. And if you tell them about it, they might do something about it. But do these have lasting effects? Who knows? And would they be good enough? If we expanded this, who knows? So this is a very basic start to what we should be doing, in my opinion. So this just takes these 27 people, these people listed in the right-hand column at the end of treatment, and look to see how many of those people who had this at the end of treatment also had it at the beginning of treatment. And you can see that most of them did. So the point is that these were people that were missed. These are people that at the beginning of treatment, we could have done something for, and maybe they would have improved at the end. So it's identifying that there are a whole lot of people that we're missing through this way of doing it. So just to conclude this, the assessments for comorbidities and co-conditions are feasible at the start and end of treatment, and referring people with TB for care for other detected comorbidities is possible and can be beneficial. I don't want to hyper promote this. This is not what I want. I think it's the minimum of what we should be doing. We should be screening everybody for everything, and we should be referring them out at a minimum everywhere in the world right now. Of course, you have to have a place to refer them to. But more importantly, you want to set things up, set systems up in place to actually provide. So just about at the end here. So this was that Calderwood paper that I talked about earlier, recently published. And they want to design a person-centered and rights-based approach to screening for household contacts. The rights-based approach is an interesting one to me. This idea that it comes back to the ethics that we were talking briefly about earlier. This idea that people with TB, you're identifying the household of people with TB, but you're not necessarily identifying the people next door. But I will say that the rights approach is, if you're going to screen for this, you better be ready to treat it, because otherwise, why are you doing it? So this is a little complicated, but person diagnosed with TB, you ask about their household contacts, and then their household contacts either get sent to a clinic or community health workers can come to the home to do all this screening that we've been talking about, integrated screening for these different conditions. And then for TB, it's found, obviously, if they're TB disease, you get them to the TB service. If they're negative, you get them on preventive therapy. Important to include preventive therapy in all of this when we're talking about household contacts. If they're HIV positive, give them services. If they're diabetes, hypertension, get them to the chronic disease services. Anxiety or depression, get them counseling. Nutritional status is poor, give them nutritional supplementation. So all relatively straightforward ideas. It's, again, having these systems in place. So I have two more slides, this and one more, just to talk about this idea of wishful thinking. People with TB, we know, have worse morbidity and mortality following TB diagnosis than people who never develop TB disease. They often suffer long-term disability and are at risk of getting TB again. We know this. People with TB often have modifiable risk factors or conditions or comorbidities, whatever you want to call them, that increase the likelihood of worse TB outcomes, both during and after completing TB treatment. We know this to be true. A TB diagnosis can be this teaching moment to educate people with TB and their household contacts about their habits and their conditions that potentially led to their TB diagnosis, that will lead to worse TB outcomes and may lead to more TB in the future. And with many of these conditions will lead just to generally worse health outcomes in the future, even if it's not TB related. So we really have that moment to really provide this care over the 6-month period, because they're kind of a captive audience. They're getting this treatment, whether we're seeing them monthly, whether they're coming to the clinic monthly. We have opportunities to really try to change behaviors. We know changing behaviors is very difficult, but if you can hit it multiple times over a 6-month period during TB treatment, we have a shot. So, but we have to get providers and people with TB informed and on board to take advantage of this opportunity to screen, educate, and manage these conditions and comorbidities. It won't work if we just have the patients willing, but the healthcare workers aren't on board. We need everybody to be on board. So these are the questions that need to be asked and answered. You know, I said at the beginning, I put that slide up that said, we want to just go in and do this work. And we do. But as we talked about earlier with Yohei, there's a lot of thought that needs to go into this. So which non-TB conditions can be screened for and treated during and after TB treatment? It's different in different settings. You saw earlier that depending where you are, there are different drivers for TB, and those same drivers are the drivers for worse TB outcomes, and they may not be the same in all areas. So we need to map the current services, what's going on in an area, to be able, we just talked about this idea of whether we integrate the services and have it at the TB center, or if there are different places for us to refer people to. We need to understand in each situation what's available and what we need to create from a service perspective. And should it be offered? So should it be offered at the TB clinics or referred out? Who should get the intervention? Is it just the people with TB? That's our immediate focus, but the household contacts? And then do we expand out to the community in these high incidence settings? When should the intervention be offered? At TB diagnosis, during TB treatment, with delay, or end of TB treatment? Some people say, for instance, we're getting a lot of kickback on our pulmonary rehabilitation study, that we want an initial spirometry so we can understand the lung impairment. And people saying, well, you can ask for somebody to get a spirometry who just was diagnosed with TB a week or two ago. That's a danger to everybody around. And we collect sputum from those people. And I realize it's a little different blowing into a spirometry, but we've worked around that and working through that, how to protect people when we do that. But we'd rather get this started as soon as possible. Waiting a little bit, a few weeks, sometimes it's handy, as we talked about earlier today, especially if take smoking, for instance. You get diagnosed with TB, and you ask the person who is diagnosed with TB, do you smoke? And they say no. And they say, did you ever smoke? Yes. When did you quit smoking? 2 months ago. When did you start TB symptoms? 2 months ago. So they're really a smoker. And they're very much at risk of jumping back into smoking as soon as they're feeling better. With TB is just a few days usually, and definitely within a week or two. You start your TB treatment, you feel better very quickly. It's wonderful to take 4 drugs. That's what it does for you. And you still have to take them for 6 months, but you feel better enough that you may light up and start smoking again. So you want to ask them again. So maybe a month in, you ask them these questions again, or maybe like we did in the study in China, train them repeatedly. Therefore, provide the care when they report it. Who should provide the intervention? That's what we were talking about earlier. TB clinicians? Probably not possible. They're very busy as is in these settings. And for them to become specialists in treating diabetes and smoking cessation and alcohol reduction and pulmonary impairment may be a challenge. We refer them to other clinics and specialists. Do we get healthcare workers to provide this care in the home? And the big thing that I'm thinking about recently is TB survivors providing this care, because they can be trained to provide a lot of it, the non-medical side of things. So what are the relevant outcomes that we're looking for? We talked about this earlier today. Improved TB outcomes, treatment completion, mortality, yes. We hope that the TB patient getting these, but TB treatment outcomes are pretty good in most places. We don't expect it to necessarily astronomically go to 99% because we're doing this. But improved quality of life is a metric that we want to look at. A reduction in post-TB lung disease. For instance, our TB Pure study, where we're providing pulmonary rehabilitation during treatment, part of the reason is to prevent post-TB sequelae from ever occurring, instead of waiting for post-TB lung disease to occur before we treat it. Management of the comorbidities, that's a huge thing. That's a huge outcome for you. If you find a bunch of people with diabetes who smoke, and by the end of treatment, you've reduced that, then you've done some good. And you've made people healthier, and they're less likely to develop TB and do other things. And that should be a primary outcome. And financial security, trying to, and again, as I mentioned, we can't forget about this, about providing them with this care free of charge, and also getting them on the course to be able to identify grants and things to help afford their TB. And I have this note here that all of this should be informed by survivors. And this is something that's very important. Over the last couple of years, I've talked to a lot of TB survivors, either focus groups or more in-depth interviews, just getting a sense of what do they think they needed during TB treatment. What care would they have wanted? And what are the outcomes that they care about? Well, we care about improving TB treatment outcomes. What do they care about? They care about being able to walk to work and end work. They care about being able to function and do daily activities. And they're not so worried about hitting the metrics that we need to hit. So that's where I'll stop. This is just a quote from George Comstock. Most of us will not win any big victories, but we can win little ones every day, and they mount up. And just throwing this slide in here, which I kind of keep going back and forth. I look at this and I think about the small steps we want to take, and everybody thinks about that. That's what you want to do. You want to take small steps, but I kind of have been contradictory in this talk. I said, yes, we want to take small steps and figure out how to do things right. At the same time, I feel like we know a lot and we're just not doing it. So maybe this person needs a little bit of a step stool to jump up and climb the ladder a little more quickly, but I'll stop there.